Okay, so I have been a medical social worker for, count them, 45 years. I've worked in hospitals and clinics. I've worked with home care, patients who are at home after hospitalization. And I've also had an agency, a placement agency called Daisy Companion Care, which placed caregivers in the home with seniors or disabled folks. The last thing I have done is be a volunteer with Compassion and Choices for 10 years. And that was helping people who've decided to be the author of their own deaths. Um, so today we're talking about facing serious illness. The next session, which is also mine, will be talking about end of life choices. Can I see a show of hands? Who of among you are not Kaiser patients? 1, 2, 3. Okay, I'm going to be speaking some things that will be directed at you, specifically about the cost. I think we have great medical services in America. Many people come to America from abroad to have procedures done or to have treatment. Um, but it is expensive if you're not a Kaiser patient. In trying to find out for you how expensive it is, I had an interesting journey. I called John Muir Hospital saying that I was someone who was facing a serious illness and I wanted to find out, I'm older and so I might want to choose about treatment options and what would a sample of costs be. And not only did I speak with many people who didn't know, but they didn't know who I should talk to. It turns out there is inquiries regarding costs. That's called a financial counselor. Then there's also pre-service counseling when you've already got an appointment with the hospital and you want to find out what the costs are. And then there's billing, which is after you've been in the hospital and they're going to tell you about your billing. I think the person that I spoke with who was the most helpful was a financial counselor. And when you call that number, they ask you to give them the date of service and your TPT code, which is the code under which Medicare pays, and the date and the doctor and so on. But Maria in Walnut Creek offered to speak with anybody who was interested in finding out more about costs. And her number was 925 947 3256. But another way of checking your costs is to check that big, thick Medicare booklet that you got to see if the procedure or the treatment that your doctor has recommended is actually covered by Medicare. And then, generally speaking, your supplemental insurance will pay the 20% that Medicare doesn't pay. But she said not always, and I don't know what the not always refers to, frankly. Um, so that can be it can be expensive. Um, in following up what Alan Bluchok talked about, I think it's really important. So I'm going to sort of go over it again. Doctors, I think, are as good as the information you give them. And so there's a publication from the National Institute of Health, which I'm going to make some comments from. In getting ready for a doctor's visit, it says, make a list of your questions or concerns and prioritize them. Make sure you're going to tell the doctor everything that's happened to you, your symptoms, your drugs, your any changes, have you been treated by anyone else, changes in medications. And the comment with these suggestions is be honest. Tell the doctor if you haven't quit smoking. Tell the doctor if you've gained weight instead of lost it. Take all your information with you, your drugs, your vitamins, your herbal remedies, your supplements, and any medical records from another hospital or another doctor. And then it says, consider bringing a family member or a friend. Tips for talking with your doctor. So again, be honest. Your doctor needs all the facts in order to provide you with the best care. Stick to the point when you're talking to the doctor. Don't create a long story. Stick to the point. Give sort of just the facts, because as you know, doctors' visits are generally limited to 15 minutes, and that has to do a lot with what Medicare pays for those visits. And so I think it's up to us to make sure that we make the best use of that time and get the most information in that we can, so the doctor can help us the best. I think for many people, and especially women, it's uncomfortable being assertive. It's uncomfortable asking a lot of questions. And I think for that reason, it's a really good idea to bring someone with you. And in my thinking, it definitely does not have to be the person who is your power of attorney. It can be just a friend, just somebody to be with you, especially if you're getting a serious diagnosis. Your emotions are going to be running high and probably will interfere with your listening, with your understanding. And the person you bring with you can help with that. I think all of us might talk to somebody who's a good friend, or maybe it is our kids, maybe it is our spouse, but even before you're having to deal with a serious illness, it might be a good idea to know someone who would be willing to come and be with you at the doctor's, and to have that person in place beforehand, I think would definitely be a stress reducer and definitely a game changer in the doctor's office. I was once asked to go to doctor's visits, many of them with a woman who was actually a retired attorney, but she knew that she was getting a little bit confused, which she was. And so I actually took notes at the doctor's visit and typed them up for her and gave them to her after the visit, which she said helped her a lot. So let's see, next.
Can I interject, Barbara? One of the things that Alan said that I don't do is he said, take 2 copies so that you're giving your doctor an actual list. You're not just talking about it.
Yeah, that's a good idea, I think.
Yeah, I thought that was better than me just having my own list.
Yes, yes.
Janice?
Good.
One of the things that I do, we record the session on our phones, and then we go home and re-listen to them.
Oh.
If he doesn't go with me, then I can bring it home and he can hear what happened and he can give me feedback.
Oh, that's
Good.
great.
Good. And your phone will actually take 15 minutes of a visit?
Oh, more than that.
Ah, okay.
That's
All right, great. Thank you for the update on the information for us older people.
Yes.
I'd like to remind people about Elizabeth Kubler-Ross's 5 stages of grieving, because I think they're appropriate to when we get a serious diagnosis. The first step is denial. No, that's not true. Anger. This couldn't be. Why is this happening to me? What did I do? I don't deserve this. Bargaining. Maybe if I go to another doctor, he won't have the same diagnosis. Or maybe if I quit smoking, I won't have cancer anymore. The next stage is sadness. And after that, basically you've arrived at acceptance. And you might go back and forth between these stages some different times, but for sure, when you're dealing with serious illness, you're going to go through some pretty heavy emotions. I'm going to talk about three types of serious illness today. One of them is the neuromuscular progressive diseases, another being the dementias and Alzheimer's, and then lastly, cancer. Our very own Judy has been dealing with her diagnosis of Parkinson's for some time. And I'd like to call on her to tell us about how that's been for her, what she's learned from her experiences.
Well, it's interesting, Barbara, when you commented about the Kubler-Ross's 5 stages, I haven't thought about that. I wonder what I've been through. I'm not sure. I was diagnosed about 5 years ago, and prior to that, I literally never had anything more than a common cold. And the only time I went to a doctor was for an annual exam. So I was totally ignorant. My symptom that drove me to the doctor was I couldn't quite control my handwriting. It wasn't a disaster, but it was odd. That was how I thought. But again, I was so ignorant, I never thought, oh, it could be a neurological problem. I didn't. I was so simple that I wasn't used to having anything. I figured that was just some nondescript problem that someone would give me, meds for. So I went to see my primary care physician, who said, I think you should see a neurologist. Even then, I wasn't terribly disturbed by that. So I go to see a neurologist, and she says to me in a very cold way, oh, I think it's Parkinson's disease, but you don't have enough symptoms for me to diagnose it. So you'll have to come back in 6 months. But by the way, you should know there's nothing you can do about it. And it's just, in a sense, fatal that you have to live with this. Thank you very much. That was lovely. So I went back 6 months later, and this doctor was a little more reasonable. And he said, yes, you have all the symptoms for Parkinson's disease. So I literally became, like a research machine trying to learn about this. And I didn't tell anyone about it, including any of my children, for a year. And part of that was, and maybe I would fit into Kubler-Ross somehow now, part of that was me getting comfortable with it. And that was important to me. I needed to, in a sense, that was how I took care of myself initially. And then when I was ready, I could tell my kids, and they were initially quite put out that I had dealt with this by myself for a period of time, but I was able to help them understand that's what I needed to do. And I have continued on to be, constantly researching and looking for anything that's on the horizon that would make, I'm not simplistic enough to think that suddenly there would be a cure, but is there a better medication is really about it. And I have, one of the things that I have learned for Parkinson's disease is that exercise looks like it's the only thing that may be hopeful to slow down your symptoms. So I am a little exercise machine, and I go to a boxing class. I've always thought boxing and football were like sanctioned violence, and it's a little hard for me to really believe that I am now been doing a boxing class for 4 of the 5 years since I've been diagnosed. And now I'm so comfortable, if I think that people might observe my behavior, I tell people that I have Parkinson's disease. People equate Parkinson's disease with a tremor. And I didn't really have a tremor until a couple of months ago. But believe me, the list of symptoms is about this high for Parkinson's disease. I mean, there are all kinds of things. There are people who never have a tremor. They've got all kinds of other things. I mean, here's a weird one. People wake up in the middle of the night and throw their hands around, and if you are a partner sleeping with them, you're in the line of their movements. You can be hit regularly. So there's an example of a strange symptom. And hallucinations are another common symptom. Anyway, they go on and on and on. I won't spend time on that. But I've gotten to the point where it's obviously something I live with. It's something I accept, and I keep on the positive road to responding to this part of me and saying, for whatever reason, it's what I have to live with, and it's my challenge in life, and I just take that and move on. Is there anything else, Barbara, that would help you to think that you know a little bit about me and that I didn't mention?
Would anybody have any questions of Judy?
Oh, yeah. Anyone want to know any more about this?
Well, congratulations, Judy. Sounds to me like you've arrived at acceptance. But I think it's good that you feel comfortable enough to tell people who might be looking at you a little oddly that,
Yes.
you know, to tell them for yourself and for their sakes.
Yeah.
Because we usually sort of avoid things we don't understand, and you're putting yourself back in the ring by speaking about it.
Yeah. Yeah. It feels easier to me.
Yes.
Yeah.
I should think it would be.
Yeah. So that works well.
Okay, let's move on to another diagnosis we all fear and abhor: dementia. Dementia is defined as abnormal brain changes which triggered a decline in cognitive abilities severe enough to impact and impair daily life. Alzheimer's is 60 to 80% of dementias in total. You know, sometimes we think, oh my God, I've got a symptom. Well, if you sometimes can't remember a name or a number or a date, but you remember it later, it's okay. If you have short-term memory loss about dates and events, and you keep asking people over and over, what was that date, or where did we go that time, that might be a little bit cause for concern. If you occasionally find errors in your checkbook, that's a common one for me. If you can't deal with your checkbook, if you can't plan to pay your bills or work with numbers, that might be more of an indicator of Alzheimer's. If you need help with computer or recording with your TV, not to worry. But if you can't complete daily tasks, like you've forgotten how to brush your teeth, then you might begin to worry. With Alzheimer's, generally, it's a disease that lasts 8 to 10 years, and it's progressively much more awful as you go along. They commonly break it into 3 stages. In the first stage, it's, you know, sort of forgetfulness. The second stage, you start to see behavioral changes and more cognitive problems. And the final stage, which can go up and down, basically, you no longer can recognize your family. You cannot speak. You cannot take care of yourself, and you can't feed yourself, and sometimes you don't even want to eat. I have a dear family of friends where, fortunately for their sakes, there was kind of an extra couple in the family who didn't have children and only did volunteer work, and so they were able to come and live with this lady. So it was a full 10 years. Interestingly enough, for 6 of those years, she was on hospice. And the hospice nurse came when I was visiting once, and I asked her about, you know, what their services were and what was important to them. They were treating all the infections that she got. They were treating all of the diseases that she got. And my friend's remark was, my mother never would have wanted to live like this. And of course, all of us who knew her knew that was true. I'd like to refer you all to the website compassionandchoices.org. Compassion and Choices is one word, lowercase, and it has tools to help you cope with doctor's visits and illness and also the end of your life. When you go on the site, you're presented with 3 boxes, and one of them is called a diagnosis decoder. And it's not going to actually tell you what the disease is. I'd appreciate everybody being on mute, please. But what it does is it gives you questions to ask the doctor. Questions like, and this is because you've been diagnosed with some kind of a serious illness. Questions like, why do I need this test? What would the result be if I don't get this test or this treatment? What if I don't want to have any treatment at all? How long will I last? What will the progression be? Give me all the treatment options from the most aggressive to the least aggressive. Tell me all my options with all the pros and cons of each. Now, for a lot of women, it might be difficult to hang in with increasingly serious and prolonged questioning like that. But I would say practice it at home. And this is when I think you would feel easier asking all the questions if you had somebody with you to be your advocate. If you kind of think, oh, well, I don't want to bother the doctor with any more questions, then maybe your advocate, who knows the questions you intended to ask, can jump in and ask those questions for you. I think that we all need to think about hanging in with the questions. I know myself, I think of myself as an assertive person, but I get in front of the doctor and I ask 2 questions and I sort of feel like anything else would be too much. And I kind of withdraw and usually go home with at least 1 or 2 questions unanswered. So, think ahead about that. Again, on the Compassion and Choices website, you can click a box that asks about dementia and Alzheimer's, your attitudes. You can click, I'm inquiring for myself, or you can click that I'm inquiring for someone else. That box leads you to a series of pages where you answer questions. And it starts out with mild symptoms and asks what you would like your treatment to be like. And then it moves into more serious symptoms like, I get confused about who's who in the family, and moving on to, I don't recognize anybody in the family. I can't speak. And it gives you the opportunity right there on the site to click on the treatment that you would want at that stage. The first being, I want all the treatment. The second is that, yes, you would like to perhaps be referred to hospice. And the ultimate would be, I don't want any treatment at all. Just please make me comfortable. And at that point, you're probably on hospice care. Then the most fabulous part of this is that you can then say, yes, I want this mailed to me. And you can have a list of all your choices that you've just made. And you can have it emailed to you or to your person who's your child, your spouse, to convey your wishes. And that person then has a paper copy of what you said when you were able to make these choices. And it's not a complete assurity that they won't try to treat you, but it's the best way you have of trying to refuse treatment and to not prolong the experience of being ill with Alzheimer's. Now, the increasing care needed by people who are suffering with dementias or Alzheimer's is a good place to step in with the ability of others and yourself to find care. In the first type of care that one family often needs is just care at home. And there are placement agencies. I think in Solano County, at least our part of Solano County, Joey with ABBA is about the only game in town, as I understand it. I know that Joey has come to speak with you. I would say that he would definitely be a gift, a resource, because he can provide everything from personal care attendance for the home, referrals to boarding care homes, and even referrals to nursing homes. As care needs advance, you would probably go through those. Sally Radigan, I think, has gone through those stages with her father. And at first they could use a few hours of care at home and then a boarding care home, and then the ending was in a nursing home. These alternatives are not cheap. They are not paid for in any way by insurance unless you have long-term care insurance. But if you don't have it, any of us at our ages are too old to buy it because it would cost a huge amount. It never has been cheap, but the older you get, the more expensive it is. People coming to the home would cost anywhere from $35 to $40 an hour. And the agencies cannot refer live-in caregivers anymore because it's regarded as being hourly work, and you can't count them being there all the time as providing them with a home. It used to be that you could, and live-in caregivers could be a fair bargain. But if somebody needs care around the clock, basically it's going to be $35 around the clock. Another alternative, if somebody needed that much care, would be a boarding care home, which is usually a small home that has 4, 5, 6 bedrooms, and they're usually owned by Filipinos, and they have 1 or 2 caregivers for, say, 4 to 6 people at a time. Again, someone like Joey is a really good resource, because if you were someone who was, say, needing care, but basically still clear of mind, you probably wouldn't want to be in a home with the rest of the people having dementia. So Joey would be able to pick a care home for you. The care homes will run between $33,500 to maybe 6 or 7 even a month if the care is more serious and heavier. And nursing homes, of course, are upwards, say $6,000 to $7,000 a month. So you can see that, again, another possibility is family discussion of, does the family have any family resources to deal with these needs for care? Because as you can see, they are really horrendously expensive. I hope you understood what I said. The care provided is custodial care. There is such a thing as professional care. If you're in a hospital for, say, surgery or some other procedure where you would require some physical therapy or occupational therapy afterwards, then Medicare, after a hospitalization, can pay for up to 2 to 3 weeks of nursing home care. And that way you avoid the needs to pay for care at home, because they'll take you and give you physical therapy, occupational therapy every day. And so maybe by the time you've graduated from that level of care, you're pretty able to take care of yourself at home. Then we have cancer. And with cancer, basically your conversation with your doctor becomes even the most important. And again, the Compassion and Choices website will give you sample conversations with your doctor. It'll give you like 24 to 46 questions that you can ask your doctor, and it'll give you the ability to choose which questions you think you want to ask, and you can click them off. And again, you can have a list of those questions that you've picked mailed to you. And it's at this point that basically you're asking for a lot of clarity on, and here it's really important that if you speak vaguely about your diagnosis and you act as though you think you might be able to go on beyond it when the doctor has just told you you've got stage 4 cancer, basically your doctor is not likely to give you the blunt facts of your stage 4 diagnosis. He's going to buffer what he says with what he thinks you can hear. If you are able to say, doctor, is this going to kill me? Am I going to die from this? How soon will I die? Will the treatment keep me from dying? If you can ask questions very, very clearly like that, you are more likely to get the doctor to tell you straight what's happening. It might be, difficult to do, but it's your best chance of getting really clear about what is happening to you. Again, with the kinds of treatments and hospitalization one might have for any serious operation, any serious diagnosis, any hospital that's not Kaiser is basically going to be a profit center. And I think we need to be aware of that and perhaps be a little less than passive as a hospital patient. I went to the hospital for 3 days with a diagnosis of pneumonia. It was a fairly mild case of pneumonia, but it scared me enough to call 911 and get taken off in the middle of the night because I was having difficulty breathing. But I was perfectly well, right? And healthy and of sound mind and body. Well, they referred to they brought in a physical therapist, an occupational therapist, the hospitalist. And that being my first experience with hospitalization, I just sort of said, oh, okay, really? You think I need this? But what I have learned since is you can say no. I don't need physical therapy. I can walk perfectly fine. I'm walking to the bathroom, but thank you very much. Occupational therapy, no, I'm good. And a hospitalist, that makes it, Alan Paluchuk said, well, the hospitalist makes it easier. Well, it makes it easier for the doctor who doesn't have to make hospital visits. I don't know that, for instance, I had a hip replaced and my doctor, my surgeon was coming in every day to see me and follow me. And the nurses, of course, were providing the care. Here comes the hospitalist every day, costing a large chunk of money to sit in a chair and, talk about my last trip. I was so insulted, but I'm not sure how you can ask to have, I think the hospitals might be something you have to endure. For sure in the hospital, if you're having difficulties with your care, talk to the head nurse, talk to the social worker, ask for a social worker. These services are available and I don't know if they cost money, but it could be well worth your time and money. Discharge planning is definitely something that you want to work with. I think somebody gave a kind of a horror story with discharge planning at Dr. Pluchak's talk, and I would venture to say that's not a usual experience. I would say perhaps that hospital and their staff were slammed with COVID patients. Discharge planners often come to see you almost as soon as you arrive to say, now, what are your plans after hospitalization? And depending on what your situation is, they will offer suggestions and can even manage the plan for you. I think that if the plan is a nursing home, I would suggest that you let them pick the nursing home because they know the ones that provide good PT and OT services. I don't think we really have the ability to choose nursing homes on our own. At least I certainly don't feel like I do. With all of these difficulties, these illnesses that you might face, the emotional component is huge. And I think that coping strategies really can help. For instance, trying to assess the situation, your whole situation, the disease and the care plan, and your needs for care and support, and write them all down. Asking questions, of course, of everyone, your doctor, your family is good. Crying is terrific. I think that in our culture, we don't tend to, we praise people who face things like a soldier. We talk about it being a battle. The truth is we are just ordinary mortals and we have a lot of emotions. And I always say that crying or expressing your anger are good ways of discharging extra loads that we just don't need to carry. And I suggest to stay with what's important, jettison the non-essentials, like, do you really need to clean the house if you're undergoing chemotherapy? Well, I don't think so. Ask someone else to do it or let it go. Build in some good stuff like movies and dates with your spouse or nights out, afternoons out. Let others help. Others really enjoy helping. And so you do them a favor by helping them find a way to feel good about themselves. And sleep and rest is always good. That's it. Does anybody have any questions about anything I've said? No, really? Sally Radigan, it looks like you've got a question you could ask. Sally Radigan has been a discharge planner with Kaiser.
For a long time. Let me think. I can't think of one off the top of my head at the moment.
Just jump in then with anything, Sally.
Okay,
you're a resource person.
I will say what Barbara said about Joey and his agency called ABBA. I worked with him for both of my parents, and I feel he's great. He's been around he's in Vallejo. He's been around there for a long time.
22 years.
Huh?
22 years.
Yeah, and he really knows what's what, and I think he's a good resource. And the thing about a placement agency does not charge for their services. They get paid basically like a finder's fee by the agency or the boarding care home that they place somebody in.
Yeah.
So you don't get any kind of charge.
Can you give his contact information, Barbara?
Again?
Can you give Joey's contact information?
Oh, I can. ABBA, Joey. Oh my goodness, I don't have it in my notes.
Well, maybe even spell, how do you spell the name of that agency?
ABBA, ABBA, like the Swedish musical group.
Oh, okay.
Oh, yes, I have his phone number, 707-704-6489. Also, I'd like to give my phone number in case anybody comes up with questions about anything I've said, or, if they would like somebody to come to appointments with them. My number is 707-747-5112, and I'd be happy to help. I also have some materials, like for instance, should you having somebody in your home, I have some materials from my agency. I wrote a couple of pages of tips for having somebody working in your home, which might be helpful. I think for most of us, we're not used to having people work for us in our home. We're not used to having servants. And I think often we can feel really uncomfortable about it, and we want to make them our friends. And I know a lot of people who basically clean the house before the caregiver comes so that they don't, no, they do that as well as take care and cook meals. And so lap it up, you're paying for it. You're paying good money for it.
Barbara, can you explain the difference between, remember I said that Mimi was disturbed because she felt she was paying for someone who was just babysitting her. And there's a difference between bringing someone in with nursing skills or someone who is, I can't remember, you described it one time.
Well, I'll bet you that she was not comfortable asking to have her do things. And a lot of times the caregivers who come into your home are a little bit shy about being there. They don't want to be too intrusive. And so they might look like they were just sitting there because they didn't know what to do.
That's a
So
good point.
I would say that you want to have a list of tasks that you feel comfortable delegating to a caregiver. And if you yourself, the family member can be the one to be in charge, rather than sometimes the person who needs the care can't actually be the boss.
That's
The
a good
kids
idea.
can, but somebody in the family's got to be comfortable saying, here's the list for today. This is what we want you to do, because otherwise they will sit there because, again, they don't want to appear
Good
intrusive.
point. Okay.
So, and the care that does not require specific skills is called custodial care. And that's the caregiver you need in your home all the time or for many hours. And it's not paid for by any insurance except long-term care insurance,
Uh-huh.
which, is there anybody here who's got long-term care insurance? Sally does. All right. Oh, Carlo, good. All right. Good. I hope you got it years ago when it still was giving away the store.
Oh,
they-
not anymore.
No, not
it's
anymore.
cheap.
When did
Yeah.
you buy yours, Sally?
We actually have a policy that's a group policy. Don worked at AT&T and they offered it as a group policy.
Uh-huh.
Probably 14 years ago or so. And so I know the rate is a little bit better than
Yeah.
than a private or just a one-person rate, but it's still, it goes up. And they have to get an okay. They have to get an okay from the state when they want to raise their rates. And so, we'll get a letter. This is John Hancock is the insurance company. And we'll get a letter that says, well, we've been trying to raise your rates, but, we're waiting on the state of California. And so far, the state's been pretty good at, keeping the increases to not a whole lot.
I pay over $8,000 a month.
Ooh.
8,000 a month?
Yeah, I mean, I'm sorry, a year.
Okay, yeah.
When did you
ours
get
is
yours,
like
Judy?
I can't remember.
Ours
About-
is like
Later than-
900 for 2 people a month.
What
So
is
that's
it?
a group rate.
Uh-huh,
Yeah.
yeah.
Well,
know
I
it's-
don't suggest anybody try and get it now.
Oh,
No.
no.
You-
Could
No.
Sally say that again? How much, Sally?
It's almost 900 a month for 2 people. So what,
Wow.
450?
Mhm.
But that's a group rate. And that's when AT&T offered it, when we really jumped on it, because that was the big advantage of it.
Yeah. Goon, do you have, because you have your background also, can you add anything to what's been said or from your experience?
Not really. No,
Good, you were a hospice nurse.
yes.
What would you say to people? I'll be talking more about hospice in my talk next week, but in thinking about hospice and maybe interviewing hospices, what should you ask to choose a hospice?
Well, if you're Kaiser has their own hospice. Sometimes, but the Kaiser also, they have, from an administrative point of view, they will sort of accept so many patients. I worked for, I belong to Kaiser myself, but I worked for, originally it was Hospice of Napa Valley. And we had, on our service, we had many Kaiser patients, especially up Valley, and in some nursing homes. And also we did have hospice patients everywhere. We also have hospice patients in board and care, and of course in people's homes. But for me, the main thing is that the hospice should be non-profit. There are some for-profit hospices, and I don't know very much about that. I don't like the idea of hospice being for-profit.
Medicare pays for hospice, right?
Yes.
What happens is, yes, Medicare, everybody on Medicare has a hospice benefit. Most people don't know that, but yes, Medicare covers, but I can tell you much more how hospice works and reimbursements and all of that. But hospice, in my book, should be free to the patient and the family. Absolutely.
Sorry.
Yeah. Go ahead.
I thought you were done. I was just going to say hospice also pays for any equipment rentals.
Absolutely.
Completely. There's no co-payments or anything. So, hospital bed, bedside commode, table, wheelchair, whatever.
Oxygen. Yeah.
Oxygen. Yes. Hospice
True.
pays for that.
Yes.
And any medications that the hospice doctor prescribes are also paid.
Yes.
Yeah.
Mhm.
Good, and what was your reaction when I told the story about my friend's family where the hospice nurse said that, oh, they treat all of the illnesses that the patient might have?
No.
That's not hospice. I mean,
hospice, we treat a hospice diagnosis. I mean, that's normally we used to have the main hospice diagnosis was simply debility and decline. In babies, it is called failure to thrive. With some of our older people, it's simply, they didn't necessarily have cancer and they didn't have this, but they were simply getting old.
yeah.
The energy wasn't there, the life desire wasn't there, they just lost the desire to live. So debility and decline, but that changed. We can no longer have that hospice diagnosis. So they have, but initially people always used to think that it was only for cancer patients, but it is not. And with all these rules, we can have a special program on hospice and what hospice does and what they don't do. But there's a lot of stuff that hospice does do And previously I talked about it is a team. You have a medical director, we have the hospice nurse, there's a medical social worker, we have home health aides, we have volunteers. We have, I mean, so there's a team of people, and then of course bereavement. So there's many factors, many hours. What I've also learned, because at my job, we had different bosses. And some of them are better than others. Others have more compassion and have a bigger hospice heart than some other managers. So sometimes things do change with different managers. That much I've learned. So a hospice can be very good, and then there's a new manager, and then it's not as good as it used to be, and then we get somebody good again, and then you can do more services. So, I mean, even managers are human beings, and some of them really are much more keen on the bottom line than others. But as long as they have hospice hearts, it's a good outfit.
Good. And what's an example of a hospice not being as good, or a manager not being as good?
When they don't allow the nurses to decide between them and the families how many visits a week they would like to make. Because the Medicare, and even if you're not on Medicare, if there is a younger person, normally the insurance companies follow Medicare rules as far as hospice is concerned. So that even if you're not on Medicare, your insurance company normally will cover you the same way. So what else?
What was your reaction to my story of the hospice nurse who said that we always give antibiotics for any infections?
No. I have seen most people, when we get up in age, will have our power of attorneys, and also I've seen some very clear decisions by the patients that says, if I have had pneumonia 6 times, do not treat anymore with antibiotics, because I'm sick and tired of going to the hospital and being treated. No more antibiotics for pneumonia. If it's a female patient and she said, if I get a UTI, please treat with antibiotics, because that can be very painful. So people have a choice. There is a patient's bill of rights, things that patients can do and also refuse. No, with hospice, we don't always treat with antibiotics. Sometimes we do.
So it's a dance with you and the patient's family.
Well, and also the doctor is involved. Sometimes, even if a hospice has a medical director, but sometimes the primary doctor has seen this patient or the family for years. They can still make home visits and go say goodbye to the patient or the family, or make several visits. So it doesn't mean that the family doctor cannot be involved, but there's always a medical director for every hospice. Absolutely.
You know,
Okay,
this is
thank you.
Oh, go on.
No, and also it depends, well, like with chemotherapy and things, Medicare is the agency or the people that decide all the rules,
Yeah,
and the rules can change.
yeah. Gail has a question.
I want to clarify something because we kind of skipped a little. So you can have custodial caregivers come to your house who just take care of daily living things, but not medical things. and then hospice comes when you need medical assistance. Is that?
No, a home care agency will come. If you have, if it's been determined that you are likely to have 6 months or less to live, then your home care agency would be hospice.
I see.
But if you are just say you need more physical therapy and you're not able to get out, so that could be reason for a home care team to come and provide professional services with a physical therapist or a nurse for wound care. You can also have a home health aide to help with showers or bathing. But that's short term. That would
Right.
only last for maybe a couple of weeks.
Okay, so I have a little experience, and it's been a while, so I've forgotten. With my parents, they had a home health care worker come and do physical therapy and things with them, and then we also hired a custodial care person for them, and got a list of the custodial care people from the hospital from which they were discharged. But vetting them, the hospital hadn't really vetted them. It was just a list of people they knew. And we found we had to be careful because some of them, well, one of them we hired was actually blind. And so that didn't really work well for trying to care. And then there was another one who.
I'll bet hospitals don't do that anymore. There's a lot of liability with
Yeah,
that.
and another one, I really like my mother's jewelry awfully well. And that took a while to figure out things were disappearing. And we thought my father had dementia. Well, he ended up with dementia, but we thought he was losing it because he said, her jewelry is disappearing. I can't find it anywhere. And he was hiding it. And then we couldn't find it when he hid it. But anyway, so hospice is only when you're at your end of life stage.
Yeah, hospice is when the doctor believes you have officially 6 months or less to live.
Okay.
However, there are rules. After the first 3 months, you are reevaluating the patient. Do they qualify to stay on or not? If they do, then they stay on, then they get reevaluated after another 3 months. And that takes care of the 6 months. If they are continuing to decline, but not as quickly as the doctor expected, then they get reevaluated every 2 months. And either they will die or they will remain or decline, but sometimes they improve. Like we take them off some medications, we provide, people coming into the home. If some people live alone, some, so it varies. But I remember the longest patient I can remember we had was a man that actually had cancer, and he lived 2 years. But again, the doctor from the beginning had expected that he was going to decline very quickly, and he didn't. So
another wonderful thing that hospices provide is volunteers.
Yes.
And pets and all kinds of visitors. I remember one patient I was involved with that, everybody was bumping into each other. There were so many, and I'm sure that raises the spirits of many people.
Yes. Yeah. No, with my hospice, we've had people come in and play music. They'll bring a guitar and they'll sing and they kind of entertain. And we've had other people that are massage people that come in and give massages to patients. So it varies very much, but yes, every hospice is expected to provide volunteers. And yeah, so that's another one of the Medicare rules and regulations.
And from what you've just outlined, we all understand that we should get ourselves referred to hospice as soon as possible if we're terminal, right?
Right, absolutely.
Gail, did you get your question answered?
But one thing hospice does not provide is 24-hour care. So we can send volunteers out like 4 hours a week, or sometimes more depending on, but 4 hours is the minimum. But we have home health aide that can go out and spend 1 hour, but we don't have people that go out and spend 24 hours a day. No,
Right.
that the family have to hire. If they can't handle it themselves, then
Yeah.
they have to get somebody in or place a person in a board and care.
Yeah.
Yeah.
I want to make sure if anyone else has any questions. So I have one. You commented, Barbara, when someone is leaving the hospital, is it Medicare would pay for OT and PT, and is that normal for
Yes.
everybody?
Yes, well, depending. I mean, I have had a series of replacement surgeries, and for each of those, basically I got PT and OT in the hospital, and then I got PT and OT
At
coming
home?
to the house for a couple of weeks. And then after that, I would have outpatient physical
Right.
therapy and occupational therapy. So for that specific, having had surgery,
Right.
then it's typical. Sally?
I think that the key to remember for the home care that would be paid for by Medicare is that the criteria is that you must be homebound. And that doesn't mean that you choose to stay home. It means that you really, it would be a great deal of difficulty for you to leave home. So if you're using a walker or a cane or a wheelchair, and for somebody to take you into physical therapy would be a major ordeal, then that would qualify as being homebound. So I used to tell people that I wondered if they were, I'd make the home health referral, but it was kind of iffy. And I'd say, do not tell the home health nurse that you went out to lunch today because they'll discharge you from home care.
Uh-huh.
Constance, did you have a question?
Not really a question, Barbara. I just really wanted to thank you for the information that you provided. It's been very helpful. And Judy for sharing your story. And for you, Sally, for adding information. And of course, my dear neighbor, Gun, for all her advice and counsel over the years on hospice. I mean, she was instrumental with our next door neighbor when she was going through her final terminal illness. So the program is just superb. I think it's just so well worth it. So thank you very much.
Thanks for your thanks.
Thank
You know, Barbara, I didn't say when I shared my story that I left out a piece that was pretty significant in that I was in a state of shock. And I think that was primarily because, as I said, I'd always been so healthy. When I started researching and reading, it was like, oh my God, this is the rest of my life, a deterioration occurring. And so how I've handled that is let's see, I'm 83 now. I've been diagnosed for about 5 years, and I'm making plans to anticipate how I'm going to be cared for in the years ahead. And I'm probably going to move to Seattle, where I have a daughter who manages a hospice, a PT and OT home health care, and a visiting nurse organization. So I figure I would be in good hands to be near my daughter, who she's also a very special, sensitive, caring, loving person. So, and she's invited me. That's the other thing. I feel incredibly grateful that she and her husband are willing to have me come up there. I don't want to live with them. So I'm working on some other arrangements at this time.
And I'd like to point out, Judy, you are still perfectly, capable of living alone and contributing to your community, which you have hugely, but you've got your long-term care plan in place, which I'm sure makes you feel much more comfortable about living today, that you've handled that with your family and your family's handled that with you. And
it does, but I
It's
don't know
great.
about anyone else, but I still live with a kind of financial terror that my resources won't last this long. I mean, in the literature, on older adults today. I mean, it's one of the things that authors will say. They'll say, people are living so much longer today. The cost is so much greater to so many people. So anyway, I don't know about other people, but I'm always have this anxiety that my money won't last, and I don't want to be a burden to my kids. That isn't
Yeah.
based in any reality. It's based in my head, in my
Well,
heart.
I think for all of us, I mean, when you're talking about $7,000 a
Yeah.
month, I don't know how many of us could last. I mean, we'll live beyond our money in many cases if it gets to that worst case scenario.
Yeah, yeah. Yes, I don't know how many of you are here for the first session, but Libby, I mean, her comment was, set up, you're going to need a healthcare fund. I thought, oh my gosh. Anyway, I didn't mean to go back and talk longer about my situation. I just
Please.
realized I didn't share the significant thing that I was terrified.
Please.
Yeah,
Eh.
I wanted to ask you that question as I sort of held back of what it was like to hear the diagnosis for the first time.
Well, it was like the first time I didn't even get it. I think I had just avoided grasping it.
Denial.
Yes, denial. I guess that was it.
Classic.
And then when I finally got it, that's how I needed all that year to really digest it for myself before I went out and went public and went and talked to my kids. So that gives you an idea of what was going on. Yeah. Yeah.
Do we have, Judy, do you have a speaker on financial planning for the inn or the inn?
Well, I couldn't find a speaker because I wanted to have a session on for this as a part of this program. So that is a great point, and I will go in search of someone again because
So important.
there must be someone in a hospital that I could snag. I mean, when I was starting to look initially, it was COVID time. Well, it's still COVID time. And no one had any time to talk about anything about, would you come and speak to us?
I'm not sure a hospital person, Judy, but you know what? There is an office on First Street for investment planning. And my suggestion would be just, you've got to take the best care of your money you absolutely
Yeah.
can figure out how to do. And perhaps an investment firm could help you place your money in such a way that it would grow a bit instead of.
Thank you. I just have the person that I think I can call. I didn't think of that, Barbara. That's
Yeah.
absolutely
I mean,
right.
they'll be happy to possibly pick up new clients, so they'll come in a heartbeat.
I will. Yes, I know someone, and I think she would do it.
Yeah, I guess a financial planner.
That's right. That's what Barbara was suggesting, and I didn't think about that. And yes.
Well, and yeah, financial planners often cost a bit of money, but my thought was an investment counselor, say from an investment firm,
Right. Yeah.
or if they do cost money and take a percentage, then you'd want to have somebody who would be willing to make that clear.
Oh, it's fine. I got someone in mind. I think
Good.
it was who I worked with before. And I'm watching my clock, and it is just about ready to ding. And Molly, I will remember to press the button this time. And next time, we'll, as we mentioned, we're getting closer to the end of life. I want to make a comment if anyone thinks that they don't want to attend a session like that because it would be morbid. I am taking a course right now called Best Life, Best Death. And it is so uplifting to focus on this that it's just been an exciting experience. So
Thank you,
yes,
Judy.
Donna?
You reminded me of something that I wanted to say, and I would like to ask you all to do a homework assignment. And the homework assignment is to literally visualize how you would like your own death to be, because we are going to be talking about dealing with our own deaths next week. And I think that it would be great if people would spend some time this week kind of envisioning what they would like, how they would like that to go?
In the course that I'm taking, that's our final assignment. We have to do that. And as the facilitator of the course said, we're all going to die, but only 20% of people have a kind of plan for what they might like if we have that chance. I mean, we don't all have that chance to have time where we would be with family or whomever. Anyway, Donna had a question or comment.
I do, thank you. And after what you just said about next week, I really want to attend, but I have a dermatology appointment that I can't miss. And I'm not coming because I'm afraid of the subject.
Okay.
I mean, I'm really prepared in many ways, but I wanted to ask you, are we actually recording these?
We're
for our
recording, that's
benefit?
right. So,
Can we
and
look
we'll
at-
send out a message, and is that what I should say, Molly? We'll send out a message.
Okay, somebody could send out a link.
We're gonna figure out how to send out the message for the links so you can find the videos.
Yeah.
Perfect. Okay, if I get back, I'm gonna come in late.
Okay.
Okay, that's fine. Any other final comments or quick questions? So Molly, why am I not in the right place?
Okay.